Special Contrast Procedures 2 with Brandy Jones. Today we're going to talk about arthrography, biliary duct procedures, and female imaging. Arthrography. The purpose is to demonstrate and assess the joint plus the associated soft tissue structures for pathological processes. Here's some nice images I've put together as a compilation for you. Joints visualized by arthrography, the most common are marked with asterisks, and that is knee and shoulder. So you have knee, ankle, hip, shoulder, elbow, wrists, and TMJs. Some physicians prefer arthrography for examination of these joints. Others prefer MR or CT in place of and or addition to. Arthrography, especially for the knee and shoulder, TMJs are very rarely done, and MRI has pretty much now taken over for that. Usually, contrast media is injected under fluoro, and then in conjunction with other modalities, further imaging may be required, like CT and or MR. So what imaging modality is most frequently used to study the soft tissue structures of TMJs? Yes, MR. Very good. Contraindications would be if the patient is known to be allergic to the iodine-based contrast media or your local anesthetic. Contrast, an iodine-based contrast media and air. For some extremities, dual contrast and air may be used. Arthrogram setup and equipment. You will need a fluoroscopic imaging table, a arthrogram tray. The one that I have and am basing stuff off of is a arthrogram tray that consists of two 20 milliliter syringes, a 60 cc syringe, 4 needles. It has 18, 20, 21, and a 25 gauge needle, 20 gauge spinal needle, a extension tubing, which is approximately 20 inches long, a 2x2 gauze, usually has 5 in the pack, 3 swab sticks, a Band-Aid with a sterile drape, a fenestrated drape, lidocaine, other supplies or additional supplies that you may need additionally to the tray would be a 10 milliliter cc syringe, sometimes different size spinal needles. This here has an example of a 20 gauge, sterile gloves for your physician, a sterile marker for marking the site, a sterile a drawing needle, which is a blunt-filled tip needle, preps, contrast media. We're using Omnipaque, and sometimes you may need extra lidocaine other than the 5 milliliters that was provided. This is a image of just showing some of the supplies. There's a sterile drape, 4x4 gauze, sterile gloves, 20 cc syringe, 2 10 cc syringes, a spinal needle, a drawing needle, which is your blunt-filled tip needle, Band-Aid, extension tubing, and 2x2 gauze that I was talking about. Patient prep and informed consent. The procedure should thoroughly be explained to the patient before the examination to preclude patient anxiety. The patient should be advised of any complications and must sign an informed consent form. An informed consent is a process for getting permission before conducting a healthcare intervention on a person. Invasive procedures consent form. Here is an example. It is good to review this and be educated about what the forms are and say. This is a great example for you. Pause for cause or timeout is when before a procedure is done, a timeout or pause for cause must be done by the entire medical team in the procedure to ensure the correct patient and all of the required elements of the pending procedure are correct by using verbal communication. This means the surgeon may repeat the name, the date of birth, might have you introduce yourself and what you do, may just say the side, the right side or left side, or whatever the invasive procedure is going to be. medical order for the procedure or script, or here are some examples that might be used. Some medical orders can be printed for certain procedures, and some need scripts for meds and can be used in patient pharmacies, for inpatient pharmacies and hospitals and so forth. Injection process. So you're going to start with number 1, site prepared. Expose the area. You may need to grab some extra sheets and or towels to cover your patient for privacy. 2, scan anesthetized. 3, fluid aspirated. 4, contrast media instilled. I have an example of 5 milliliters of positive and 80 to 100 milliliters of negative, which would be room air. 5 would be the needle removed and wrap the part. And 6, you may need to exercise the joint. Needle placement. When the site is prepped, draped, and anesthetized, the physician introduces the needle into the joint space. Usually a 25 gauge needle is used to drain fluid. If the fluid looks normal, which is usually a clear with a yellow tint, it may be discarded. If the fluid is cloudy, it should be sent for analysis. When all fluid is aspirated, contrast may be injected. So you might need to have an extra form, a lab form, a microbiology form available to fill out if the physician decides to send the fluid away. Pathologies. The primary indication for arthrography procedure are trauma, persistent pain, limited motion resulting from any of the conditions, dislocation, a joint capsule tear, ligament tear, a meniscus tear, and rotator cuff tear. Some findings that you might see from dislocation would be displacement of the bone from the joint. Joint capsule tear would be rupture of the joint capsule. A ligament tear, rupture of the ligament. A meniscus tear would be rupture of the meniscus. A rotator cuff tear would be rupture of any of the muscles of the rotator cuff. After the procedure and/or discharge instructions, make sure to explain the following after the procedure. 1, it is important to drink lots of fluids. It will get rid of the dye when the patient urinates. The more they drink, the faster this will happen. 2, keep the injection site clean and dry for at least 24 hours. 3, remind the patient that has had anesthesia and injected into the joint. This means that he or she may not be feeling joint pain. The anesthesia should wear off in 1 to 6 hours, and the pain they felt before may return, and this could be slightly worse from them aggravating the area. 4, try to rest the joint that had the injection as much as possible for the next 24 hours. And 5, you may ice the area. So one thing that's important that we tell patients is not to get a bath for the next 24 hours, not to go in the water like a pool or a sauna or anything like that. Arthrography of the hip. Hip. Evaluate hip dislocation in children before and after treatment. In adults to detect loose hip prosthesis or confirm the presence of infection, but mostly pain and arthritis. Here is some great images of hip injection tray items. As you can see, there's a 20 milliliter syringe, 3 10 milliliter syringes. The physician I work with uses a 10 milliliter syringe for lidocaine, a 10 milliliter syringe for Kenalog, and a 10 milliliter syringe for Marcaine, and a 20 milliliter syringe for my contrast. You have a blunt filled tip needle to fill up your contrast with your 20 milliliter syringe, extension tubing, your ChloraPrep, your gauze, fenestrated drape, sterile drape, your sterile gloves, sterile marking pen, Band-Aid for when you're done, and your needles, of course. Radiographer has a lot to do. Not only do you have to get the room ready, get your patient ready, inform your patient, and then you're going to get them on the table. They're going to get on, position them so they are supine on the fluoroscopic table. You'll have to drape them with some sheets and or towels to expose only the hip area, and that way they have some privacy. You'll want to pull this floor tower over and place a needle or metal finder at the superior aspect of the femoral head neck junction. You'll use your marking pen and mark the area, and then you will prepare the area with antiseptic solution. Now, of course, this may vary at different institutions. Sometimes all you're going to do is get the patient on the table and the radiologist will do the rest. Sometimes you'll run the fluoro tower for the radiologist while they stay sterile and do everything. It just depends on your facility. So radiologist and or physician will anesthetize the planned area needle track, advance a 20 to 22 gauge spinal needle directly into the joint. Usually fluoroscopic spot image shows the needle hub and superimposition over the needle, so it shows that it's puts in a good spot. You will then aspirate a little bit of fluid and then inject with the contrast. If there is a suspected joint effusion, consider a syringe aspiration of fluid to avoid overdilution of contrast. After dripping contrast into the needle hub to eliminate air, attach the contrast-filled tubing syringe. Inject a small amount of contrast to confirm intra-articular position. The contrast should flow freely away from the needle tip, opacifying the joint capsule. Here is a YouTube video that I have found. It's a great little video. You guys should take a watch. Arthrography of the knee. Indications for the knee. When tears of the joint capsule, menisci, or ligaments are suspected, the knee is subject to stress, especially during sports activities. Pathological processes that occur during trauma, ligament injury, tears or degeneration of the menisci, sometimes a valve for Baker's cyst, including tears or collateral cruciate ligaments, injury or tears to the menisci again. For example, a non-traumatic pathologic process that may indicate an arthrogram is a Baker's cyst, which usually communicates with the joint capsule and is in the popliteal area. These can be very painful. Knee structures of main interest. Here is a great picture that shows you the joint capsule, menisci, the collateral ligament, the cruciate ligament, and some other minor ligaments that you'll need to know. Joint knee anatomy review. These should be in your Bontrager's book, if I remember right, but it's good to know where your ACL, MCL, your LCL, and all sit in your knee, and your synovial joint, patella, where the bursa are. So these AP and lateral images that are labeled are great. I would get to know your anatomy pretty well. So for the knee arthrogram, the procedure would be the patient's going to be lying in a prone position. You want to call your radiologist in or PA. They're going to come in and sterilize the area of interest. You add some drapes, localize the area of interest, probably using your metal pointer and or needle in the fluoro tower. And then you're going to cover the fluoro tube with some sterile drapes. The doctor is going to manipulate the knee. The doctor will then inject lidocaine to numb the area. Then the doctor will inject contrast to ensure the correct location and determine whether the bursa has been penetrated. After injection of contrast, the doctor will take a series of images with fluoro and may ask for radiographs like AP and lateral. Then the doctor may manipulate the knee again after injection for evaluation. Arthrography, the fluoro imaging. You want to make sure you're using your protection. Make sure you're wearing your lead and your lead gloves. You also want to closely collimate your views to each meniscus. You're going to do 20-degree rotation of knee between each exposure. The fluoroscopic and radiographic imaging. The knee is stressed during fluoroscopy. The physician is going to do this with use of a compression band sometimes. So evaluation criteria for the radiographic imaging, the entire articular capsule is outlined, proper AP and lateral positions, optimal exposure factors, your marker and patient ID are visible. Usually there's 6 or more exposures. Collimated fields do not overlap, and each meniscus is visualized and centered. As you can see an example here with these 9 images, and they are progressing as they do 20-degree increments of rotation. CT arthrography looks like this after the dye has been injected and sometimes can be performed. Here is an example of an AP and a lateral knee. This patient had just had a total knee done and an arthrogram afterwards. This is a normal study. Here is an example of an AP and a lateral knee with a abnormal study. Arthrography of the shoulder. Purpose. Arthrography of the shoulder uses single contrast or double contrast injection to demonstrate the joint capsule, rotator cuff, long tendon of the biceps, and articular cartilage. Some clinical indications are shoulder arthrography is indicated when patient presents with chronic pain or general weakness or tears. Shoulder anatomy, I would get to know your shoulder anatomy. Here are 2 great pictures I have found that shows the bursa and your glenoid fossa and your articular capsule around the shoulder. Here shows some of your muscles. This is a great anatomy. I would make sure you know and are aware of it. Rotator cuff. The acronym SITS is often used for the collection of muscles that make up the rotator cuff. You have 4: supraspinatus, infraspinatus, teres minor, and subscapularis. I would know these. These are very commonly injured. Sometimes the doctor can do certain exams and to figure out which one it is that is bothering the patient. Sometimes you need to do a arthrogram to figure that out as well to see the damage of it. Procedure for shoulder, the patient's going to be lying down supine. Call your radiologist or PA, sterilize the area, you'll add your drapes and localize the area of interest, and cover the fluoro tube with some sterile drapes. You'll help the doctor fluoro the shoulder to localize the joint space and mark with a sterile marker. The doctor's going to manipulate the shoulder. Sometimes they'll do some scout projections before this begins, internal, external. Sometimes they will have you do a glenoid fossa, a Grashy, transaxillary, or intertubular groove. The doctor will then inject the lidocaine to numb the area. The doctor injects the contrast to ensure the location and determine whether the bursa has been penetrated. After the injection of contrast, the doctor injects a MRI contrast and or prescribe pain medication. Then the doctor may manipulate the shoulder after the injection for evaluation. Shoulder arthrography, the single contrast procedure is usually 10 to 12 milliliters of positive contrast media. A dual contrast procedure would consist of 3 to 4 milliliters of a positive contrast media and 10 to 12 milliliters of negative contrast media. Negative contrast media is room air. Here's an example of the needle going into the synovial space. The final needle is used usually because the joint is deep. It demonstrates the joint capsule, rotator cuff. The joint is exercised after injection of contrast to spread the contrast material into the articular surface. Shoulder. The joint is exercised after injection of contrast and the spread of contrast material into the articular surface. Here's a great image that shows this. What are the suggested shoulder positioning views? So you may do a scout, which consists of your internal and external rotation, sometimes a Grashy for your glenoid fossa, sometimes a transaxillary, which is a PA oblique, or a intertubular groove or bicipital groove. But you're never going to do a Y, just keep that in the back of your head. Shoulder arthrography. Here is the list of suggestive views. It shows your scout, AP projection, internal or external rotation, your Grashy, transaxillary, and your intertubular groove. PA, transaxillary projection. Warning, do not attempt to rotate, force, extension, or abduct the arm if a fracture or dislocation is suspected. Clinical indications are fractures or dislocations of the proximal humerus, bursitis, shoulder impingement, osteoporosis, osteoarthritis, and tendonitis. Your technical factors, 40 inches, 10 by 12 lengthwise, IR. You can use grid or non-grid for smaller shoulders. KVP range is 70 to 85. The patient position is in an erect or recumbent position. The patient is positioned at 70 degrees from PA, rotating the affected side towards the board, towards the detector. The part position, the arm is raised superiorly at 160 to 180 degree flexion. The head is turned away from the affected arm. The CR is directed 30 degrees caudal and centered at the level of the scapular spine to pass through the scapulohumeral joint. Anatomy that's demonstrated is a lateral view of the proximal humerus in relationship to the scapulohumeral joint, and articulation is visualized. The coracoid process of the scapula can be seen on end, as you can see here in the labeled image that I have provided for you. And there's a nice image of showing how to do this position. Tangential projection of the intertubular or bicipital sulcus. Clinical indications or pathologies of the sulcus or groove, including bony spurs of the humeral tubercles. Technical factors would be 40-inch SID, 10 by 12 IR lengthwise, non-grid, KVP range 70 to 80. Patient and part position, your patient is standing, leaning over the IR to place the humerus 10 to 15 degrees from vertical. You'll flex, your elbow should be flexed, and the posterior surface of the forearm will be resting on the table, and the hands supinated to hold the image receptor. Turn your head away from the affected side. The central ray will be perpendicular to the IR, directed to the groove, which is mid-anterior of the humeral head. The groove can be located by careful palpation. Anatomy demonstrated would be the anterior margin of the humeral head, which would be seen in profile. Humeral tubercles and the intertubular sulcus are seen in profile. Wrist arthrography. Wrist arthrography is done when the patients have chronic pain, trauma, limited motion. Wrist arthrography, radiocarpal, midcarpal, or disto-radial ulnar. Radiocarpal joint, the needle target is the radioscaphoid space through the scaphoid holounate joint. Mid-carpal joint, posteriorly, a needle is placed in the scaphocapitate and the triquetrohamate area. The contrast is injected until it flows into the capolunate joint compartment, as you can see the band here on the image. Distal radial ulnar joint, the needle is directed near the radial border of the ulnar head, then inserted deeper into the joint space, as seen in this image here. Wrist, usually a scout image of the PA wrist is taken before the exam begins. You'll clean, prep, and sterilize the area. The doctor will numb the skin around the joint using a small needle with medication, usually lidocaine, but not always. The doctor may remove fluid from the joint. The doctor then will inject contrast dye, or air with a long, thin needle under fluoroscopy. It takes the images of the joint in different positions with either X-ray, fluoroscopy, and or MRI or CT. TMJs. TMJs are done when patients have trauma, chronic pain, difficulty opening their mouth, used to rule out stretched posterior ligament that allows the disc to slip, causing pain, almost non-existent. Usually MRI is preferred nowadays. Clinical indications, clinical signs of TMJ, arthralgia, arthritis, including pain in the jaw, movements, and restricted jaw opening. No or minor pain relief are justified for conservative treatment with either non-steroid or anti-inflammatory drugs, occlusal splint, or exercises of the jaw. Clinical signs of the possible internal derangements and or adherences. TMJs are usually preferred to be done by MRI nowadays. However, MRI cannot reveal conditions like adherences and perforations in the disc and posterior attachment, since the examination consists of still images. So it still may be warranted once in a blue moon. TMJs, the exam is performed with the patient in a supine position, lying on their side, with the TMJ of interest facing upwards. When the patient's head is tilted slightly towards the table and then rotated upwards. Eventually, you guys will learn how to position the patient for TMJs, and they're kind of going to be on like an axiolateral position. All right, to sum it all up, I have this YouTube video for you guys to watch. Intermission. Okay, guys, we have hit our halfway point. If you need to go to the bathroom, we'll give you 5 minutes. Get up, stretch, and then we will continue. Biliary duct procedures. T-tube cholangiography and ERCP procedures. Biliary duct anatomy. Here is a great image. It's going to show you your left and right hepatic ducts coming down into the common bile duct. Your common bile duct goes all the way down, branches off to your cystic duct and to your gallbladder. Then you come back out to your common bile duct, follow it down, and then you can go into the pancreatic duct and so on. T-tube cholangiography. A post-operative T-tube cholangiography post-surgery. So the surgeon may be concerned about residual stones in the biliary duct. The T-tube shaped catheter is placed during surgery into the common bile duct. The catheter extends to the outside of the body and is clamped off, and usually has like a little bulb type of sac that hangs, a plastic device that will collect any drainage. Here is a nice example of a T-tube that I have found, so you can see actually what it is, and then you can see the example of the anatomy of it sitting in the common bile duct. T-tube cholangiography is performed in radiology department, usually under fluoro. Usually this is post 10 days of the procedure. Of course, if there is something going on with the patient, they may do it sooner. However, it's usually 10 days after the procedure. Contrast media is injected into the T-tube catheter, and they kind of light it up for us as seen in these pictures here. And you can see all the structures, see if there's any stones residually left in the common bile duct. Clinical indications, residual calculi, undetected stones that may remain in the biliary ducts after surgery, strictures, a region of the biliary ducts that may have narrowed as demonstrated during the operative cholangiogram. Contraindications, hypersensitivity to iodine contrast, infection to the biliary system, elevated BUN or creatinine levels. Patient prep. The patient should be NPO 8 hours prior. The patient, take a good patient history, find out what is going on, why, and explain the procedure to the patient, what's going to happen. It's very simple and quick. You'll change the patient into a gown. You might want to put a couple towels around the area just to make sure you don't spill anything on the patient. Keep them nice and clean. For the procedure, you're going to prepare the fluoroscopy suite for fluoro. You're going to place the patient supine on the table. Place a sheet at the waist over the patient. Maybe place a towel around the abdomen of the site to keep them covered and have their privacy, and also to keep so you don't spill anything. Take a scout image. Usually this is kind of like a chaptamen. You kind of want to see part of the chest and then part of the abdomen. Setup requires usually a small bottle of Omni is what we use, but it could be vary per site and what they use. Usually about a 30 cc syringe, a small adapter, possibly, and some Kelly clamps and emesis basin. So usually you want to clamp off the bag that's going to come off of the tubing so that way it doesn't spill or anything of the sort. Procedure. Attach the syringe to the end of the tube that extends from the patient's body. Contrast and water. Sometimes the radiologist may like to mix some water into your contrast. Fluoro is required while the radiologist injects. Follow the standard precautions when using and handling bile. Obviously, you don't want to be touching it. Take some radiographs if requested by the radiologist when done. Here is an excellent example of a T-tube coming in from outside the stomach, labeled T-tube. Then you can see the T portion sitting at the top of the T portion sitting in the common bile duct, and it appears to be injecting contrast, and it's lighting up the whole common bile duct, right hepatic, and common hepatic duct. Post-procedure imaging. Here is a picture of your abdomen, and here is some larger pictures of the anatomy, just showing you what is going on. ERCP. What does ERCP stand for? Anyone? ERCP stands for endoscopic retrograde cholangiographic pancreatography. Yes, mouthful. That's why we call it ERCP. The purpose is for examination of the biliary and pancreatic ducts. It is performed by a gastroenterologist with a team. Now, we have at our facility a special team in the endosuite, and we use a C-arm in the endosuite for ERCP. But this can be done in the department as well. All right. ERCP, endoscopic retrograde cholangiopancreatography. The procedure is endoscopic inspection, cannulation, and injection of the biliary ducts with the use of a duodenal scope. An endoscopy refers to the inspection of any cavity of the body using an endoscope, an instrument that allows illumination of the internal lining of the organ. ERCP is an examination of the gallbladder, pancreas, liver, and the ducts tubes that drain these organs. Small ducts from the gallbladder and pancreas flow into larger duct that drain the bile from the liver, which is the common bile duct. The common bile duct drains into the small intestine through an opening called the ampulla of Vater. Therapeutic and diagnostic. The purpose of therapeutically, the ERCP may relieve certain pathological conditions through the removal of the cololiths or small lesions, or other purposes such as to repair a stenosis, a narrowing or blocking of a duct. The purpose for diagnostically generally involves the insertion of an endoscope followed by a catheter into the ducts using fluoroscopic and contrast. Clinical indications for ERCP is patency, the openness of the biliary or pancreatic ducts, undetected cololiths or residual calculi, small lesions or strictures within the biliary or pancreatic ducts. Indications: when clinical and radiographic findings indicate abnormalities in the biliary systems or pancreas, jaundice, evaluation of pancreatitis, evaluation of possible pancreatic cancer, and to remove gallstones that are not passing through the ducts into the small intestine. Contraindications are allergy to iodine-based contrast, infection of the biliary system, pseudocysts of the pancreas, elevated BUN and creatinine levels. We will be using contrast. It's an iodine-based, water-soluble contrast medium. My favorite is Omni. Most of other facilities will use Omni, but it just varies in your area and facility. Procedure. A fiber optic endoscope is passed through the mouth into the duodenum under fluoro. The physician locates the ampulla of water and places a small cannula into the ampulla. Contrast is then injected into the common bile duct. The procedure takes anywhere from 30 minutes to 2 hours. Recovery time is anywhere from 1 to 2 hours. The patient is monitored before, during, and after the procedure. Medications affect blood pressure and pulse. The endoscope may cause spasms to the duodenum and the sphincter of Oddi. Therefore, the doctor may ask for glucagon to be injected. Both the bile ducts and the pancreatic ducts are visualized. The patient should be kept NPO for 1 hour post the procedure to help prevent any kind of aspiration. ERCP setup, it can be done 2 ways. One in the fluoroscopic room, which is pretty much rare anymore, or with OR equipment in the OR suite and or endo suite. If the ERCP procedure is performed in a department with a floor room, the OR team will bring their own equipment. This includes the anesthesia cart, any kind of medications, all probes, tubes, catheters, anything for the procedure to the department. The patient would be on our fluoro table. It gets pretty crammed. There's a picture on the right here that shows you an example of the patient in an LAO position with the endoscopic cart at the head of the patient and everything else around them, not including our anesthesiologist. Okay, and then on the left, there's a picture if it's going to be performed in the OR with a C-arm. Patient position. So know your anatomy. Looking at this is giving you a great example of where it's positioned, but just remember the patient is going to be laying in an LAO position on the table, so you've got to have your brain flip and rotate this over, and so you need to think about where to center and what you're looking at. Here again is an excellent image showing you all the anatomy. You just need to remember and get used to this. Good luck. Switching gears. Female imaging. Hysterosalpingography. So a hysterosalpingogram, aka HSG for short, is a contrast media study of the uterus and uterine tubes. Female reproductive system anatomy is an AP and a lateral view. The purpose is patency of uterine tubes, visualize the uterus and uterine tubes, visualize abnormalities, and visualize an Assure stent. An Assure stent is placed in the tubes to block them. Clinical indications would be infertility and demonstration of the intrauterine pathology. So for infertility, one of the most common indications, the HSG procedure may help diagnose and function or structural defects. A blockage to one or both of the uterine tubes may inhibit fertilization. The procedure may be therapeutic as the contrast may straighten a narrowed, tortuous, or occluded tube. Demonstration of intrauterine pathology. When a patient's symptoms indicate the presence of an intrauterine pathologic process and normal bleeding, pelvic pain, pelvic fullness, and are exhibited by patients. Lesions that are demonstrated may include endometrial polyps, uterine fibroids, intrauterine adhesions, as well as the diagnosis of pelvic masses, fistulas, habitual spontaneous abortions, and congenital defects. Contraindications would be pregnancy, active uterine bleeding, and pelvic inflammation. Also, iodine, if the patient would be allergic to any iodine contrast medium. Procedure. The test is usually done between day 7 or through 10 of your cycle. The physician will place the speculum into the vagina. The uterine cannula or catheter is inserted through the speculum into the cervical canal. Contrast is injected through the cannula into the uterine cavity, then flows through the patient uterine tubes and spills into the peritoneal cavity. Spill is absorbed and eliminated via the urinary system, usually within 2 hours. Patient prep and instructions. The patient should be thoroughly informed about the procedure, advised of any complications. Many women feel cramping, especially when the dye is injected. Women who have blocked fallopian tubes may feel intense pain. Some women become lightheaded and may have spotting. Patient prep and instructions. Bowel prep. Patient may be asked to take a laxative the night before the procedure, empty the bladder just before the exam. Physicians may advise the patient to take anti-inflammatory pain medications such as Advil or Motrin an hour before the procedure and or another dose later in the day after the procedure. Ibuprofen and antibiotics, some mild and heavy cramping as the catheter is inserted, and pre-medicating with a painkiller can help minimize discomfort. In some cases, antibiotic may be prescribed for after the procedure. Patient prep and instructions. You'll have a consent form signed, your invasive consent, the pre and post count for your safety for your instruments if you're using sterile instruments. Here's an example of the invasive consent forms. You guys have seen these before. Pre and post count form. You need to count if you have sterile products that have to go back to sterilization. Note imaging department protocols may vary. A scout usually consists of a 10 by 12 area crosswise. The CR and IR are centered to a point 2 inches above the superior to the symphysis pubis. Same thing for your RPO and LPO, and you'll just oblique them, RPO and LPO. And then your post would be the same as your AP scout. Evaluation criteria, the pelvic ring centered within the collimated field, the cannula and or balloon catheter should be seen within the cervix. The opacified uterine cavity and uterine tubes are centered to the IR. Contrast medium is seen within the peritoneum in one or both tubes are patent. Appropriate brightness and contrast demonstrate anatomy and contrast medium. Right and or left marker should be visualized without superimposition of the anatomy. The patient will be laying in a semi-lithotomy position for insertion of the catheter, and then they will be brought up and have to have their legs straightened out a little bit to have the fluoro tower come over top of them. Room setup, set up the floor table with a sheet and a pillowcase for the patient to lay on. Place a chuck under the buttock area. Remember, the patient will be close to the end of the table during the procedure. An extra sheet to cover the patient's legs and waist down. The patient must be in a gown with an opening in the back and nothing on from the waist down. And you will need a light source for the physician. There's some supplies you'll need other than the tray, betadine, some sterile gloves. Sometimes you need them, sometimes you just need them for the physician. A small tray of sterilized gauze, 4x4 sponges, a 10-pack usually, a 20 cc syringe for contrast. The contrast usually I like to use this Omni. Sometimes they have other things at other places. Hystero tray, catheter disposable sometimes. In the bathroom, you should have some pads and some wipes for the patient to clean up. It's going to be sticky and they may have some bleeding or spotting after procedure. Contrast, you're going to be using an iodine water-soluble contrast media. Here are two examples, Omnipaque and VisitPaque. Histero tray. These are some things that is found on the one that I generally use. You have a sponge stick, a single tooth tenaculum, Kelly clamp, a needle clamp, a cannula, a small and large speculum, a small and large acorn, which is the white and the black little rectangle or triangle looking thing, and some Teflon tips. Number 1, name me. Sponge stick. Number 2, single tooth tenaculum. Number 3, Kelly clamp. Number 4, a needle clamp. All right, name me. Number 1, cannula. Number 2, your small and large acorn. Number 3, Teflon tips. Some other supplies. Sometimes your tray may vary. This is just an example of a different tray. And they also have disposable catheters. We use these quite often and seem to be a little less barbaric for the patient. Here is an example of what's happening when the catheter is placed in. The catheter goes in the cervix, and then the balloon is placed so it doesn't get pushed back out. And then dye will be injected into the uterus. As you can see on the image on the right of the x-ray, you can see the triangular uterine shape with the contrast filling. It's going into the tubes and spilling out. So this is a normal procedure. This is nice. Anatomy. The most distal end, of which arches over the ovaries, bilaterally containing finger-like extensions, are called fimbriae, then opens up into the peritoneal cavity. This is a image of a normal HSG, a smooth triangular uterine cavity and spill from the ends of both tubes. You can see the going into the catheter and the dye going into the triangular shaped uterus, going along the tubes, and then on each side is spillage. This is an HSG showing blocked tubes. There is no spill. There's no dye seen at the ends of the tubes. You just see it going into the uterus here. This uterus seems to be off to the side a little bit, and you can see it going into the tubes, but then it never spills out. So this is a not normal study. Post-procedure, depending on what the physician radiologist found during the procedure, it could be good or bad news for your patient. So just be there for your patient. Sometimes it may be devastating for them. So just help your patient. Let your patient know that there's contrast is clear and can be sticky. Walk them to the bathroom. Sometimes they may have a vasovagal response and could pass out. So stay with them. Place towels and or wipes for them to clean up themselves. Provide a feminine pad just in case they did not bring one. Sometimes they have spotting or bleeding and or sticky stuff still coming out. Here is a really great YouTube video. It's a little bit longer than I like, but it's a great video. Here is a histero video. This was one of the students' projects. This is from class of 2022. They did a great job, and I just wanted to share it with you guys. Okay, the end. We made it.